Well, good night, everybody. Thanks for coming in. It looks like we've got a pretty good group here. I'm Mickey Reinhorn. I'm gonna help moderate this with Rana Higgins from Wisconsin. And so we got a pretty good lineup today. We're really gonna talk about pain management. It's really important, obviously. We're gonna learn how we can do better. I've learned a lot from this group of speakers. So I'm just going to get the ball rolling, and I'm really excited to turn it over to Arielle Perez from North Carolina, who's going to talk to us about predictors of high and low opioid use after inguinal hernia surgery.
Okay, let me make sure I can get this up here correctly. Thanks, Mickey, for the introduction. My name's Arielle Perez from UNC. Thanks to the moderators and to the ACHQC for the opportunity to talk about this. I'm going to go over predictors of low and high opioid tablet consumption after inguinal hernia repair. This is analysis by the ACHQC Opioid Reduction Task Force. I have no disclosures. So, you know, here on this talk, I think we can all agree that there definitely is an opioid epidemic. The Health and Human Services published this information. In 2018, over 10 million people misused prescription opioids. So the Opioid Reduction Task Force was formed in September of 2018, and it's been chaired by Dr. Mickey Reinhorn. It's a multidisciplinary committee. It's composed of 16 members from multiple specialties, including surgery, anesthesia, and primary care. The goals of the committee was really to identify ways to reduce opioid prescribing and opioid consumption in hernia repair patients. We did this via data evaluation, surgeon education, and patient education. The Opioid Reduction Task Force started a few different initiatives. The first was to provide recommendations for post-operative pain management, and this information can actually be downloaded from the QC website, and it can be inputted into discharge instructions or even just printed out as a card as a handout for patients. But really stressing using Tylenol and Advil as adjuncts prior to any sort of opioid use. Secondly, the task force created and implemented an optional ACHQC opioid data module, which started in March of 2019. It was used to collect preoperative behavioral and opioid substance abuse history risk factors. And then we also included as part of the module, collecting information on opioid prescribing and multimodal pain management by the surgeons. So we were able to collect both the type of opioids prescribed, the milligrams, and the number of tablets, as well as the medical adjuncts with Tylenol and ibuprofen, whether prescriptions were provided or not. Lastly, we were able to collect patient opioid consumption using the patient reported outcomes assessment sheet. And this can also be downloaded from the ACHQC, and usually this is handed out during the post-operative assessment. And we were able to evaluate and see how many opioid tablets patients were taking. So Dr. Higgins actually presented the data, in January 2021 on inguinal hernias. And we found that there were 1,188 operations which were collected into the QC, performed by 80 different surgeons. And what we found was that only 26% of surgeons prescribed less than 10 tablets to patients. And really 70% of surgeons were prescribing 10 or more tablets of opioids to their patients after inguinal hernias. And when we looked at what was consumed, we found that about 90% of patients took 10 or less tablets of opioids. And when we looked at just that 90%, we found that 40% of those patients consumed no tablets of opioids at all. So it seemed like patients were consuming significantly less opioid tablets than what surgeons were prescribing. So, you know, how are we able to guess who was the patients that were going to need more or less opioids? So for this study, we looked at 2 years after implementing our opioid reduction task force initiatives, and it seemed clear that surgeons and patients were being conscientious stewards of opioid use after elective surgery, but it seemed that prescribing and consumption patterns still remained highly variable and incongruent. So with this study, we sought to identify predictors of low and high opioid consumption after elective inguinal hernia repair. We did this by taking elective clean inguinal hernia repairs, which were entered into ACHQC from March 2019 to March 2021. We looked at clinically significant patient demographics, medical comorbidities, operative details, quality of life measurements, and prescribing data. And then we identified the variables with our task force members as well as the ACHQC statisticians. We performed 2 multivariable logistic regression models, which we used to identify statistically significant predictors of patients who took no opioid tablets, as well as patients who took more than 10 tablets. So as of March 1st of 2021, there were over 76,000 patients. We included elective clean inguinal hernia repairs with 30-day follow-ups, and we excluded patients who had a concomitant ventral hernia repair or some other sort of procedure. We only included patients that had patient-reported opioid consumption, as well as patients where the surgeons had entered their opioid risk factors, as well as the opioid prescribing details. So in total, we actually were able to find almost 2,000 patients. Of those almost 2,000 patients, 59% underwent a laparoscopic or a robotic inguinal hernia repair with mesh. 35% underwent an open inguinal hernia repair with mesh, and 6% underwent an open inguinal hernia repair without mesh. Of those patients, 50% took 0 opioid tablets, 42% took 1 to 10 opioid tablets, and only 8% took more than 10 tablets. So we looked at the baseline characteristics, and we did find statistically significant characteristics of patients, as well as with their operations. But what we did was we took both the preoperative variables, which were associated with low and high opioid consumption, and then we, as our task force, found clinically irrelevant variables. And then the statisticians verified that we did have sufficient event rates that would allow us for analysis. And those variables included the age, gender, smoking status, ASA class, substance use history, any behavioral health history, if patients had taken opioids within the last 30 days, the anesthesia type, the laterality, the operative approach of previous mesh was present, the number of opioid tablets which were prescribed, the OR time, as well as the quality of life pain domains at baseline. So in the first analysis, we looked at predictors of taking 0 opioid tablets after elective inguinal hernia repair. And what we found was that older age, having an ASA class 2 or less, having no history of opioid use, using local anesthetic during the surgery, having a quicker operative time of less than 1 hour, and also prescribing fewer than 7 opioid tablets were all predictors of taking 0 opioid tablets after elective inguinal hernia repair. And I'd like you to note that really prescribing 7 or fewer opioid tablets was fairly highly correlative with taking 0 opioid tablets. In our second analysis, we looked at predictors of taking greater than 10 opioid tablets after elective inguinal hernia repair. And what we found was that younger age, having being a current smoker, having an ASA class greater than 2, having taken preoperative opioids use at baseline, having an open mesh hernia repair, having a longer operative time greater than 1 hour, having a higher quality of life pain domain at baseline, as well as being prescribed more than 7 opioid tablets after surgery, were all predictors of having of patients taking greater than 10 opioid tablets after elective inguinal hernia repair. And once again, if you look, the surgeon prescribing more than 7 opioid tablets was one of the highest correlative variables within our analysis. So the limitations of this study were the ACHQC collects surgeon-entered prospective data, and there's incomplete or incorrect information which is subject to human data entry error. Also, the study is limited to self-selected surgeons that participate in the ACHQC, and these surgeons are likely focused on quality improvement. So prescribing and patient management practices of the surgeons and patient information collected here may not represent those of other general surgeons. Lastly, prescription refills were not tracked in the opioid module, So the total prescribing by surgeons may have been underestimated, and patients may have required more opioids than actually entered. So in conclusion, patients most likely to not require opioids tend to be older, healthier, opioid naive, and appear to have had local anesthetic administered during their elective inguinal hernia repair. Patients most likely to require more than 10 opioid tablets were younger, were smokers, had more comorbidities with a higher ASA. They had a history of opioid use, and they also tended to have an open mesh repair. So surgeon prescribing seems to directly correlate with both low and high opioid consumption, and actually seems to be one of the methods that surgeons can very much affect how many opioid tablets patients take after surgery.
Great, thank you so much, Arielle. We have one question. How big of an effect did operative approach have on predicting high opioid use, given the fact that you found that higher opioid use was associated with open repair?
It actually was not as big. Let me see if I can share my screen here one more time. It really was not as big of an indicator as you would think. Let's see here. Let me pull that back up. When you look at the open mesh repair versus an open non-mesh repair, the odds ratio was much higher for the open mesh versus open non-mesh versus the open mesh versus the MIS repair. The odds ratio was much lower. The highest correlation was really with the surgeon prescribing number of opioid tablets. Here you can see it, 3.32.
And how did, and just talk a little bit about the 7 tablets, because you talk a lot about the cutoff of 10. So was that from the statistician found, was that what the statistician found in terms of the curve, where the cutoff was, or how did you guys come up with 7?
You know, in terms of the 7, it was, correct me if I'm wrong, Clayton, but it seemed like that was actually the number that the statisticians had chosen as
they thought that was the break point. They thought that was the break point at which that was the easiest way to make it a dichotomous type thing.
Yeah.
Yep.
Arielle, that was great. I want to question the audience, not you here, but it seemed to be that a number regardless of other comorbidities and how many opioid tablets our patients take, right? How many people in the audience have a problem with that?
You cut out for Mickey.
You cut out a little bit, Mickey. Can you just repeat that?
Just, you know, you're suggesting that the most powerful influencer on opioid use post-op is the number of tablets we write, independent of other risk factors or the procedure we do.
Correct. Yes.
And so what do people in the audience think about that?
Well, I'll answer that. Maybe other people can kind of chime in as well. I think this, you know, when I look at all of your list of your multivariable analysis, you know, most of the time I'm sitting there thinking, well, what of these findings can I modify? What's going to be painful to modify for inguinal hernia, and what's going to be easy to modify? I mean, I think this is pretty compelling that, you know, what we have to modify is what we prescribe and kind of how we approach these things. And Mickey's kind of changed my opinion on this. I started at 50. You had me down to 10. Yeah, I mean, I was 50. I have a long story to tell about why I was 50, because it was really hard to get refills. We had to FedEx stuff. So I just thought I was doing the right thing. Like I wasn't, you know, I thought that's what you should do. So I'm down to 10. So, I mean, if this looks like is 7, basically, you know, the number, and I saw Don kind of mention the good thing of, you know, this is not the first study to find that. And I think it's really important to kind of personally kind of bring some of that up as this correlates with that. But I think that a lot of times those other studies are looking at really large data sets, national data sets and whatnot, that don't really have kind of the granularity of looking at the different procedures, the different approaches, whether you use mesh, whether you didn't use mesh. And I think that that's one of the things that as our data with more granularity kind of supports previous things, it really only strengthens those arguments to do that. So, if we're supposed to be at 7, I mean, I there's no compelling reason not to be based on this data. So 7 it is.
Arielle, do you think surgeons who prescribe less also educate patients on the risks of new opioid dependence, in your opinion?
I do. I think in my opinion, it's pretty ballsy to prescribe no opioid tablets. I think it's the surgeons that really are being proactive in trying to get their patients to take no opioids and really focus on adjuncts of ice, Tylenol, ibuprofen. And so I think when you don't prescribe opioid tablets, it tends to be the surgeons who do take a little bit more time to educate their patients.
And, to Dr. Rosen's point, it used to be much more difficult to send refills, and now it's actually easier. So if anything, providing that opportunity to prescribe less is actually better, because then if the patient happens to need a refill or something like that, it's not as difficult for them to be refilled as before, when you had to send paper prescriptions or FedEx or however it was done.
Yeah.
Can I add one thing to what Arielle said? Because I think, to me, as somebody who is the ultimate convert of this process, and I'm really taking what you guys said to heart, there's some things I think that surgeons that resist this, we often forget and to help. So I think one of the most important things is I personally, I don't actually educate my patients about opioid dependence at all. I haven't found that to be very helpful. I think most of these people don't think that's going to be the problem. I kind of pose this in a completely different way. I learned this at the QI Summit 2 years when you guys first started this. And I mean, this might be obvious to many, but this kind of was revolutionary to me, was that if you tell people you're taking something away, they're going to resist it. So I think it's very important to promote this and all the work that you guys have done to make that clear. This actually isn't as much about opioid reduction as it is about alternative treatments. And it's trying to move away from opioid as a first line to first line Tylenol, first line Motrin, first line, ice, and all the things, and focusing on that stuff, not taking what, quite frankly, I always used to do, which was just say, well, take 2 Percocet, you'll be fine, I'll make you feel better. Is really, that to me is the big branch point in the education, that although the end of it is less opioids, that's not actually the treatment. The treatment is opioid alternatives. And I think that kind of PR and messaging, especially to some of the stragglers, about people who are kind of, still have fear about prescribing not enough for their patients, is if you feel like you're not giving your patients something they need, you're going to resist that. And so I think that's you guys, I've kind of all brought that up, but just to really highlight that, I think it's so important for surgeons and for the patients.
Yeah.
I can comment real quickly. There was a question about, type of fixation. There's a lot of questions like that in terms of comparing tacks with suture for robotic repairs. And at the end of the day, we worked really hard with our statisticians when we did the multivariate analysis to really boil this down. We're only allowed so many covariates for the model to be accurate. For overprescribers, it was only 8%. So we really kind of had to be very thoughtful about what variables we chose. And that just seems to be a different type of question, or for a dedicated analysis, whereas we tried to pick kind of more broad things like open versus MIS instead of doing those types of specific technical types of things. So we were really thoughtful about how we chose our covariates and tried to keep it to be broad categories.
Thanks so much. We have one person who raised their hand, and then we'll move on to the next talk. Augustino Cervone, did you have a comment or question?
I do. Why isn't our goal for no opioids? So I've been opioid free for all my hernias, inguinal, ventral, incisionals, for the past 3 years with the use of gabapentin, ibuprofen, the OnQ pain buster, various techniques. Why wouldn't our goal be for no opioids?
You're you're speaking to Mickey's heart. That is the goal. Definitely, absolutely the goal. I completely agree with you. I use a lot of Robaxin. We use it in our bariatric population and in all our hernia patients too. I know Mickey feels strongly about this, but I completely agree. I think shifting the dial, like Dr. Rosen said, toward alternatives and trying to steer away completely from opioids should be the goal. But I think we're trying to move the dial, and we're just trying to see how we can move the dial as best we can.
Yeah, so I think your question is a great segue to Clayton's talk, and I'll tell you that I commend you for not using opioids, and we strive to do the same, and I think that should be our goal. We eliminated this talk in order to have enough time, but I think you should speak up more often and share what you're doing with others so that we really can learn from you of what it takes to do that. But I think the one thing that Mike Rosen taught me 3 years ago when we started this is small baby incremental steps. I went to 0 opioids over a 7-year journey. And I went from 20 to 12 to 10 to 6 to 3 to 0. And so, we got Mike going from 50 to 7 in a matter of 3 years. So he's going to be preaching about 0 in another year or so. So I think we're going to get there, but it's going to take baby steps, and that's how change happens. So please share with us what you're doing on the chat. And I'll invite you to the committee if you're willing to participate, to the task force. Because love your input.
Hearing that. All right, next we have Clayton Petro from Cleveland Clinic presenting about the ACHQC opioid task force. What's next?
All right, I apologize. I some of this might be a little bit redundant with Arielle's talk, but at the end it kind of branches off into something else, and hopefully it will address some of the questions that came up. Bedtimes can be a little loud at my house, so I did pre-record this.
Hi, everyone. I'm Clayton Petro at the Cleveland Clinic, and now that Arielle has updated you on our most recent analysis of the data, I'd like to put that in the larger context of what we as a task force set out to do, what we've accomplished so far, and what some of our ideas are moving forward. I have no disclosures. So again, I'm going to kind of outline, to put things into perspective, what our initial objectives as a task force were. What are some of the things that we've accomplished after analyzing some of the data and putting together some publications, and what our ideas are for projects moving forward, and how you all fit into that in terms of potential participation as well. So in September of 2018, our opioid task force was formed. There were 16 of us, surgeons, anesthesiologists, primary care providers, and Mickey Reinhorn has done a really good job quarterbacking all of us and making this as productive as possible, even through the pandemic. Our goal, again, as a group, was to reduce prescribing and consumption of opioids after hernia surgery. Our initial task was to create some of the modules that you've probably grown familiar with within the Quality Collaborative. So the first is within the preoperative comorbidity section, the opioid detail questions that are optional at this point, where you can document some of the risk factors for opioid abuse. And then in the post-discharge pain management module, this has recently become...
Wait, can you guys not see this?
No.
And Clayton, we just see the first slide, but nothing's advancing.
Oh, all right, hold on.
I don't know if many of you know this, but Clayton's actually a ventriloquist, and he actually was on America's Got Talent. He actually made it to the semifinals, but was stuck being a hernia surgeon.
That's amazing. Renaissance man.
We truly try and recruit the finest.
All right. How about that?
I think you're sharing the wrong part of your screen.
Yeah.
You have like.
It's like.
Yeah, we see your slide deck, not the video you showed us.
All right, that's so frustrating. All right, let me try it. Hold on, let me try this again. I mean, at this point, I might as well just present it. Shoot.
Yeah, we won't mind the
I can tell you that
it's okay.
The Cleveland Clinic group chat is blowing up. We're all supporting you.
I'm afraid to look at my phone right now.
The only way
you know
how to attack you personally.
All right, this is what. Okay, here I found you. There we are. All right, is it showing now?
No.
All right, so
No.
I'm just gonna present. Hold
I
on.
would unshare your screen and reshare it. See if that helps.
There we go. That's better. Need
right.
to see if it advances. Yeah, there we go.
Let's just do this. Let's just do this live then. All right. So so like I was saying, so the first task we did was we made the modules that you're all familiar with. The second one of putting the data into your 30-day follow-up, I believe recently became mandatory, so that we can keep track of what we're prescribing patients post-op. So the very first thing we did, and I think Arielle mentioned this already, was at the summit in 2019, we looked at the first 6 months of data of what we were prescribing versus what patients were consuming. And again, what we generically found was that we're prescribing a lot more than what patients are consuming. Half the patients are taking no opioids for inguinal hernias, while 55% of us are giving more than 10 tablets. So I think, generically, again, for umbilical hernias, 2/3 of patients are taking less than 10 tablets. 2/3 of surgeons were giving more than 10 tablets. And so we asked surgeons, we challenged them to not prescribe more than 10 tablets for inguinal and umbilical hernia. We put together all these educational supplements, again, that Arielle mentioned, as well as email blasts, videos, testimonials posted on the ACHQC website. And then we looked at that data a year later to see, what we were able to do. And like she showed from our first analysis was that we were able to get surgeons to reduce the frequency with which they were prescribing more than 10 tablets. For umbilical hernia repair, that increased 13%, and for inguinal hernia repair, that increased 6%. And this is a little controversial. I mean, certainly we had enough patients that we had a very small p-value, but whether or not this improvement was considered significant, we kind of debated that amongst ourselves. But we were able to conclude that, in general, we are overprescribing, but patients are still consuming a lot less than what we are prescribing, and that this is going to need to be a continuous quality improvement effort. Certainly, I think one of the biggest takeaways from the second analysis that we performed, the multivariate analysis, was again what Arielle discussed, in that one of the largest predictors, the largest predictor of overconsumption, has to do with our overprescribing. And so when you put all of these three analyses together, what it boils down to is that we know we're overprescribing. We know that our overprescribing is related to overconsumption. And we know that we are able to change, but I think it is fair to say at a minimum that we are resistant to that change. And so what's next? So I think that if we're going to be honest, I think to talk about the elephant in the room of why are surgeons so afraid to change? Why are we afraid to go to 0 tablets? I think that this is such a fundamental change in our practice and what we were taught that I think that we cannot help but be biased. And I think we all have some predilection to assume that our patients are somehow just a little more complex, or they're medically more complex, and therefore they can't have things like NSAIDs because they have chronic kidney disease. And so those patients need more opioids. Or our patients are traveling from farther, so the stakes are higher if we somehow mess it up and they can't get their pain under control and they drove back home. So I think that we all have convinced ourselves, at least those of us that are still reluctant to change, that our patients are somehow unique. And so I think that whatever the next thing we do needs to come right at that. Certainly we're not the first people to try to get surgeons to change. Or to get, figure out what technique you can do to get surgeons to prescribe less and patients to consume less opioids. Really, you can break those down. This was a nice review into 3 different categories: clinician-mediated, patient-mediated, and organizational-mediated. So those that are clinician-mediated are kind of things that we've already done. And that can have success rates up to 53% reduction of opioid prescribing. Now, some of that is skewed depending on when you started your campaign. So if you started your campaign 8 years ago when we were all prescribing a boatload more opioids, you're going to have a huge impact, as opposed to if you started like us. We started this kind of when opioid reduction strategies were already in the consciousness of surgeons. Patient-mediated techniques are also found to be very effective. And one of the most effective techniques are organizational mediated things. So for instance, if your electronic medical record auto-populates to less than 10 tablets, that can have a huge impact on what you or your physician extenders or what your residents are routinely sending patients home with when they fill out the discharge dot phrase or whatever it might be. And so when you look at what our project is moving forward, I think it has to address a few things. It has to allow us to continue to optimize our opioid prescribing. It has to harness the data from the ACHQC. And specifically, I think we should capitalize on the fact that we have the granular data of the ability to compare what we are prescribing to what that specific patient is consuming. And it should allow us to address the elephant in the room, which is why our surgeons so reluctant to change. And ideally, it could even capitalize on some of the other efforts from other task force committees, such as the Data Integration Committee. And so I think one of the things that can address all of those things are individualized data reports for our own opioid prescribing and patient consumption. I think if we routinely had individualized reports that showed what our own patients were consuming versus what we were prescribing them, and we were able to break that down by procedure-specific metrics and have the ability to compare that to our peers, and that this was continually reinforced on perhaps a biannually or quarterly basis, I think that would do a lot. I think that there's something fundamentally different about that than looking at the group data of the entire ACHQC. And I think that checks a lot of the boxes. It gives us a way to move forward and continue this effort of quality improvement to reduce prescribing. It does harness that specific type of data we have, which is our specific patient prescribing versus consumption. It addresses the reluctance of surgeons to change. And our Data Integration Committee has already been working on putting together these quarterly reports. And so I think that that's something that we are close to achieving. Now, how exactly we do this is still up in the air. I think it's a really exciting idea would be to randomize us as surgeons to either being able to look at the group data versus our own individualized reports and see which group of surgeons has more of an impact. The other, if that becomes from a design perspective, too difficult to navigate, then I think one of the things we can just do is look as a group in more of a QI type design, start giving all of us individualized reports and see how that affects our prescribing moving forward. And so one of the last things I want to leave you with is just a call for your engagement. Be ready that these reports are coming. And I ask that you continue to try to make yourself better, engage with the report when the time comes, and see if you can continue to reduce your prescribing. So I'm happy to take questions at this point.
Thanks so much, Clayton. That was great. Live, it was just as good as it would have been recorded. So great job. We'll take any questions. If you have any questions, you can put them in the chat box.
Clayton, I'll ask you, how challenging do you think it'll be to get that level of individual data for each surgeon is the first question, and then to randomize it, because it seems like that would be the perfect trial.
Yeah, randomizing might be a lot to overcome, particularly if you start having to talk about getting an IRB at every institution, particularly maybe, I don't know, I think that might be a lot to overcome. But I think if you just look at it from more of a QI standpoint, that could be kind of our safety net, which if we cannot overcome the ability to randomize surgeons. First of all, I mean, I would just, by show of hands, would anyone be up for that? Would that sound like something you would all be interested in, is being randomized to seeing your group data versus the individualized report?
Augustino,
You can either use a thumbs up or the hands up sign to vote.
We're seeing lots of hands come up.
Yeah, I do think, I think this is whether we do it in a randomized fashion or not, this is what has to happen. I think one of the things the reason that we put together the quarterly report was because that was something that came out of the survey to all the folks putting their data into the QC. They want more back. They want more to be fed to them about, not just what is shown within the QC as far as the metrics, but I think this is something that we can offer to people putting their data in, particularly now that it is that part of the module is mandatory. I think this is the prime time to do this. You can feed that data back to the surgeons, and I think if you looked at the data every quarter and saw what you were prescribing versus what your patients were reporting that they were consuming, there is not a more individualized, compelling argument to prescribe less. And so I think that's what needs to be done. And we're going to work hard to figure out what the best design for that is. But I think even if we can't, get the greatest randomized controlled trial in the world, I still think it's the most effective thing that should be done. And even if it's just in the mechanism of a QI effort, I think that's where we're headed.
Well, Clayton,
I think Ben. Hey, Mike, I'm gonna have you hold on. Ben raised his hand, and I think he's got something pertinent to say about this. So I'm gonna let Ben go first.
Good job as task force lead there, just shutting up Mike. That's you've passed goal number 2, so good job. Hey, Clayton, great presentation. Really enjoyed it. The one thing that we haven't really addressed is what's the role of local anesthetic adjuncts, either just with local anesthesia, short and long acting, tap blocks, ilioinguinal nerve blocks, those type of things. Are those things we should be incorporating as just kind of routine baseline type stuff? Or is it still more the patient expectations, education, and other things? It just loved some comment on that, some discussion around that.
Yeah, in the multivariate analysis, the use of local was right up there with number of tablets prescribed. So I would push back to Mike a little bit that when you look at the list of things that you can modify, that is something that, I think a lot of us take for granted that of course you use local, but I don't know. Perhaps there are instances where we forget to do that, or I'm not really sure what the reason not to would be. But that did come out in the multivariate analysis, use of local anesthetic. In terms of things like tap blocks, for an inguinal, I would kind of lump that all together. Use of local tap block, I think, would be generically the same, or maybe I'm not thinking broadly enough.
No, but I think it raises a good point about whether you use in a minimally invasive approach, whether it's laparorobotic, if you do ilioinguinal nerve blocks, or you inject in a tap plane, if you can reduce opioid use, because we've seen some very differences between robotic and laparoscopic, for example. So Ben, definitely something that we can look even deeper into, like a deeper dive. Mike, you had a question about what type of local?
So wait, one thing, Ajita and Kripata are signed in with my thing because they didn't email. So like, just in case some shaky things start coming through the chat, that's not me. There's like 3 Mike Rosens here. I'm the only one showing my face. So I don't use the chat thing. I just run my mouth. So, but I think that was Ajita might have asked what local.
It was me, and we just can't have 3 Mike Rosen faces on here, so that's unacceptable. I was just asking about, are we recording the type of local for these in terms of like Exparel versus short acting, and is anybody using Exparel for inguinals?
So that data is in the QC. I think that very, very much like the question about fixation. I think when you start getting into that level of granularity for these type of analysis, there's just only so many variables you can pick. And I think that some of these things, in terms of just, you could pick, all the different types of local and anesthesia. You could do a dedicated analysis just using those variables, because that is all in the QC. It's just a matter of deciding what type of analysis you want to do. This was trying to look at everything, but you could probably have, if you include all the types of anesthesia and the techniques and the type of local, then, that's its own analysis. We just didn't have room for that.
Yeah, and I think, the questions that everyone is asking here are questions that we need to answer. And I think it gives us a lot of really good information and things to go forward and try to analyze these things and come back over the next few years and try to figure out what we can do. I think just to keep things moving, we're going to switch gears a little bit, both from Cleveland Clinic to the Ohio State, where Courtney Collins is going to talk to us about prehab, abdominal rehab related to hernia surgery and how it affects post-op outcomes and obviously pain with it.
Okay. All right. Hi, everybody. So I'm like Mickey so eloquently said, I am from the Ohio State University. And just to talk about something completely different from what these guys have been talking about, I'm going to talk about preoperative activity level and its effect on outcomes for our ventral hernia patients. So, we all know all about, obviously, hernia repair. It's the most commonly performed elective general surgery procedure in the country and costs us billions of dollars per year, which we don't have to spare. And over 500,000 Americans are affected by ventral hernias, either pre or post repair. And what I really want to kind of think about for this talk is really just the effect that hernias have on patients' quality of life, both in terms of cosmesis and pain and, really a function of the abdominal core. So again, I know I'm preaching to the choir here, so I won't belabor this point, but, complication rates for ventral hernias vary just really extremely from 5 to 60%, depending on patient population and clinical scenario. And even patients who have, kind of quote unquote successful repairs, at least, in the operating room, can have long-term issues with things like recurrence and limitation of function and cosmetic concerns. We've all gotten much better at these over time, so our, I think patients do better after surgery. For sure, recurrence rates have gone down as technology has improved and we've refined our techniques. But, I think going forward, it's important that we start looking at things we can do outside of the operating room. Technology is only going to advance so much further. Techniques only going to change so much, so kind of what are areas we can look to, really outside of the operating room and in the perioperative period to help our patients do better. And so I think this dovetails nicely with the concept of abdominal core health, which I know a lot of people on this call are very familiar with and or helped invent. Kind of just to drastically oversimplify, the field of abdominal core health is really a concept that encompasses the stability and function of the entire abdominal wall from, diaphragm way down to pubic bone and all the associated quality of life metrics that go along with it. And how it really relates to what I'm going to talk about is that, it really makes sense to me that if your abdominal wall is healthy, or as healthy as it can be when you walk into an operating room for hernia repair, you're going to do better. Sewing healthy tissue to healthy tissue is going to do better. Patients are going to recover faster and hopefully have longer lasting repairs. So, what can we as surgeons do to really get our patients' abdominal walls in the healthiest possible, scenario we can prior to going into the operating room with us? And so that kind of brings us to the concept of prehab. And I could talk about prehab for a really long time and go down a huge wormhole because it's something that's been, really talked about in surgery for a long time. And this really starts from the orthopedic literature. And I don't know if anyone's had a joint procedure. I tore my ACL a few years ago. And, the utilization of perioperative physical therapy and encouraging activity is really just dogma with orthopedic surgeons. You do physical therapy before, you do physical therapy afterwards, you walk, you do all kinds of stuff. And their thought is that, really enhancing those tissues, using those tissues that they're going to be sewing has been shown to have better outcomes. And it helps you get your function back and get you back to the person that you should be faster after surgery, which I think is something that hernia surgeons can definitely appreciate. In abdominal surgery, we do know that prehab has been shown to improve outcomes in multiple scenarios, be it liver resections, colectomies, vascular surgery, and bariatrics. We really don't know a lot about how it works in hernia surgery, kind of despite, I think, the kind of obvious overlap between orthopedics and us. There is one study that was done on bigger hernia patients that were undergoing ventral hernia repairs, and patients that underwent a prehab program initially showed lower rates of complications and decreased lengths of stay if they underwent an exercise program compared to patients who didn't. But 2 years out, they really didn't show any differences. And aside from that, we really don't know much about how activity level affects hernia outcomes. So kind of with that in mind, and again, just kind of thinking about how these fields overlap as orthopedic, prehab, and kind of our functional outcomes, We wanted to look at the QC to see how pre-op activity levels affect our elective ventral hernia patients. So we looked at patients who were over 18 who underwent ventral hernia repairs between 2013 and 2019. We included all ventral hernias, regardless of kind of morphology, pathology, or surgical approach. Patients were only excluded if they didn't have pre-op activity on file or if they didn't have 30-day outcomes recorded. Our primary outcome was 30-day complication rate, anything at all that was recorded in the QC, but we also looked at things like length of stay, quality of life, and post-operative pain. We compared a lot of socio-demographic characteristics. I won't list all of them for you, but age, gender, comorbidities, BMI, as well as hernia morphology like size and recurrent versus non, as well as surgical approach, laparoscopic, robotic open, and OR time. Our comparison group was activity level as reported in the QC, and there are 4 levels that we capture. And what I kind of want to emphasize before I go into the results is this is a pretty low bar if you think about it. Like this is, a sporadic exercise or exercises once per month, a moderate one is once per week. So we're not really, there's a lot of room to grow here, kind of regardless of which box you check. So we're really not looking at patients to be, really super, 5 times a week exercisers. This is a nice low bar, I think very attainable. We did a univariate comparison of kind of all these characteristics and then did multivariable logistic regressions, adjusting for significant factors as well as activity level. So when you look at our patients, we had about 3,000 people that met our inclusion criteria. And importantly, 51% had no activity whatsoever. And this is by their report before surgery. So again, we have a lot of room to improve things here just at baseline. And not surprisingly, only about 10% of people labeled themselves intense exercisers, remembering though that only means that they exercise 1 time per week or more. Not surprisingly, our more active cohort was younger, and thinner and had lower ASA scores compared to our not as active cohorts. In terms of hernia morphology, our more active patients also had narrower and shorter hernias. They were less likely to have recurrent hernias and were more likely to undergo an open procedure. Looking at outcomes, you can kind of see similar to what we've seen in other surgical specialties. People who had higher levels of activity had shorter lengths of stay and lower rates of postoperative complications. This is primarily driven by wound issues, including surgical site occurrences and, importantly, surgical site occurrences that required intervention, all of which were significantly lower in patients who had had at least some pre-op activity. Kind of interestingly, at least to me, we really didn't see a difference though in the quality of life metrics, at least at 30 days. Whether you were again, an intense activity person or a more sedentary patient, there really wasn't much a difference in your change in Hercules score or your pain score. I do want to emphasize though, this is only at 30 days. And I think a lot of times patients spend, 30 days still in really just in the post-op acute recovery phase. And I think longer term outcomes would be really important to look at here. So when we look at our model, looking just at postoperative complications, a lot of things came into play. A lot of this isn't surprising, things like ASA class, wound class, hernia size, and surgical approach. But activity level did retain a protective effect against postoperative complications. And I think what's really meaningful about this slide is that any level of preoperative activity conferred some kind of benefit for postoperative complications. So going from nothing to 1 time a week still decreased your odds of postoperative complications by about 25%. So again, we don't need to ask patients to do looking at this, extrapolating a little bit, it means that, asking patients to be just a little more active might confer a pretty significant benefit. So overall, I think the takeaways from this, and again, this is a very preliminary study. There's a lot more work to be done here, but I think the 1,000-foot view is that, importantly, the majority of our hernia patients don't really do much activity at all before surgery. So we can certainly ask them to do a little bit more. And patients who have even small amounts of physical activity, again, just going from, looking at from 0 to 1 time per month demonstrates a protective effect against postoperative complication, at least on retrospective analysis. Right now, we don't have any obvious benefit on quality of life at 30 days, but again, it's important to note that we didn't look at long-term outcomes in Hercules or the pain scale. There's obviously some limitations here. We all love the QC, but of course it has its limitations in terms of a very targeted surgeon population, as well as most of these variables being self-reported. The activity variable itself, I definitely agree is a little imprecise. It is has to be entered by somebody. Patients have to report it. We don't know what kind of activity they're even talking about, whether it's, low level walking or, significant abdominal core exercises. So, for sure, there's a little bit of nuance in here that we're not getting to. And I think the most important limitation is just that patients who are, able to exercise at least once per week are likely healthier at baseline, and so probably have lower surgical risk. We did try to adjust for that in our models, but obviously no model can perfectly alleviate all of those issues. We also had relatively small sample sizes, particularly for our higher level activity groups, which only had a couple hundred. And this really limits our ability to look at a lot of different factors or to look at long-term outcomes where our population was too small to do any kind of multivariable modeling. Nevertheless, I think there are some kind of important take-homes here, which is really that even small amounts of activity may confer significant benefits to hernia patients. And again, this really does overlap nicely with other findings, both in orthopedics and in abdominal surgery, that have been shown to improve outcomes when preoperative activity is encouraged. I do think a lot more data is needed on long-term outcomes, in particular with things like recurrence and quality of life, which we were really only able to scratch the surface of here to really understand what the potential benefits of rehabilitation are. And kind of as my last point, I just want to talk about this new initiative that the QC has undergone for abdominal wall physical therapy. And this is something that at Ohio State, we've really embraced and are really excited about. And this is a initiative that has targeted abdominal wall physical therapy designed specifically for hernia patients. This is really a multidisciplinary effort across multiple institutions with surgeons, physical therapists, all kinds of people. And this has pre and post-operative exercises that are designed specifically for abdominal wall patients and that are supervised by physical therapists. This is abdominal core strengthening. This is pelvic floor exercises. I've learned a lot about the pelvic floor from doing all of this. I know Ben has too. And also encourages overall fitness through things like walking programs. This is our patients, at least at Ohio State, have responded really well to this. This is something that's really exciting. And I think it's for a few reasons, just kind of anecdotally, we don't really have long-term data on our patients quite yet because it's a fairly new initiative, but this is something that really gets patients excited as active participants in their surgery and in their recovery. And so this is something that, initially when we pitched it, we're like, no one's going to want to do this and go to physical therapy, but they actually really, really do. This is something that patients really do seem to like. It's something that they feel like they can do. It helps get them moving. It helps get them moving in a safe way, and really has made their recovery, I think, a lot smoother. As I mentioned, we don't have any long-term data on our patients yet. We are looking into doing that. I think there's a lot of work to be done here, even just in terms of qualitative work to kind of see what effect this is really having on patients. But I do think this is a really exciting new field, and just based on the preliminary data just about activity level, I think could confer real benefits long-term. So I'm very happy to take any questions. Again, I know it's not about opioids and fighting the opioid epidemic, but I really think this is an important initiative that can make a huge difference to a lot of patients.
That's really great. Thank you so much, Courtney. Any questions from the audience before we move to our last talk? We're just getting a little close on time. And did you have a comment?
Yeah. Quick question, Courtney. Thanks. It was an awesome presentation, and I think summarized some of the things that we're finding here at Ohio State really, really well. The thing that we all struggle with is, how do you convince others that this is a good thing? Honestly, I was kind of blown away, like you mentioned, how much patients just really engage and really like being a part of these type of things with physical therapy. But everyone's looking for, well, what outcomes does it really improve? And that's the thing I'm struggling with. Any thoughts on where we should go with that, or should we just move entirely away from the typical outcomes we measure in hernia?
I think that, and this is kind of going back to convincing surgeons how to think differently. I think everyone's always going to be very married to things like recurrence rate and, and post-op complications. I really think a lot of that will improve. Length of stay is certainly something that's consistently been shown to improve with kind of targeted prehabilitation and other disciplines. So that's for sure a really easy metric. But I do think the majority of the gains we're going to see here are going to be in quality of life and and those kind of things that surgeons don't typically think about, but are increasingly becoming more important. Hospital systems now routinely collect patient-reported outcomes, routinely go off of patient satisfaction, that kind of thing. So as we sort of move to these more patient-centered models of care, I actually think this is a great time to really get on board with initiatives like this that are really sort of focused around patient outcomes and patient-centered care.
I have a quick question, just in terms of if others are interested in trying to promote this at their own facility, what is, or the mechanics of an interaction with the physical therapist? Is it one session where they teach you these exercises and then you go off on your own, and then they do maybe one post-op session where they teach you, or are they meeting with them regularly to go through the exercises?
That's a great question. And I will answer, and I will preface this by saying that Ohio State, because our hospital is literally next door to a football stadium, has a really robust physical therapy and rehab department that not everyone may have. So here they ideally, and this is kind of take COVID out of this equation, because that obviously changed things a little bit for a while. They have at least one preoperative visit where they go over, where the physical therapists go over the preoperative exercises and also go over the postoperative exercises, so they know what to expect after surgery. Ideally, and depending on what campus you are, our physical therapy team will meet with you in-house if you're still here. And then they have multiple visits post-op, usually starting between, depending on your surgery, between 4 and 6 weeks afterwards. They try and see them at least once or twice per month, and then it's tailored for each patient depending on progress. Now that's a really big lift from our physical therapy department, and something that, again, I know not every facility has available. But I think at bare minimum, having one kind of preoperative visit and then at least one postoperative visit to go over things, and hopefully maybe at least once per month, is something that kind of keeps patients on track. We were actually more worried about the patients not wanting to do that, because that's a big lift for them, especially because a lot of our patients are older. But patients are really, really enthusiastic about this, and so far the compliance has been really great.
Courtney, this is great. I think the shift, when you think about an ACL repair, no one would think about not doing months and months of physical therapy post-op. And, at least with hernia surgery, maybe we should be thinking about it this way as well, because it's core health. So this is great. Thank you.
And I'm hoping it'll actually, kind of going back to outcomes that matter, this actually, I think, would dovetail nicely with some of this opioid, thing. If we can teach patients how to move safely, because a lot of what patients get out of this is just knowing how much pain is okay to feel. And, because I think patients feel often they can't move after surgery if it hurts at all. And so then they take a lot of opioids so they can move. And so kind of going to physical therapy here, our physical therapists are like, no, it's going to feel a little bit sore. It's okay. You can, here's how to do it. I think will also decrease opioid use, honestly.
Great. Thank you so much, Courtney. And lastly, we'll be finishing with Aldo Fafaj talking about a randomized controlled trial of Exparel versus placebo in complex abdominal wall reconstruction TAP blocks.
Okay. Good evening, everyone. I'm a general surgery resident at the Cleveland Clinic, so I'd like to thank the QC for the invitation to present our study looking at the efficacy of liposomal bupivacaine on postoperative pain following abdominal wall reconstruction. So these are our disclosures, and of note, this study was supported by a grant from Pacira Pharmaceuticals. In the interest of time, I will skip the introduction slides and go straight to the aim. With this study, we aim to investigate the effect of liposomal bupivacaine on opioid use after open abdominal wall reconstruction when compared with simple bupivacaine and placebo. So this was a double-blind, 3-arm, registry-based randomized controlled trial performed at the Cleveland Clinic. And inclusion criteria were all adult patients 18 years or older undergoing a clean or clean contaminated ventral hernia repair with mesh placed in the retromuscular position. Exclusion criteria were allergy to bupivacaine, moderate or severe liver disease, renal insufficiency, and chronic opioid use. On the day of surgery, following a esophageal, our investigational pharmacy randomized the patient and delivered the allocated treatment arm into the operating room, which was then subsequently injected into the TAP plane by the surgeon. Postoperatively, all patients received a patient-controlled analgesia device, and our preferred drug was hydromorphone. However, if the patient had any contraindication to this drug, fentanyl or morphine were used. In line with our enhanced recovery after surgery pathway, all patients received acetaminophen, gabapentin, and oral oxycodone, again, unless there was any contraindication to any of these drugs. For the study purposes, all opioids were converted to morphine milligram equivalents. The primary outcome of interest was opioid requirements in the first 72 hours after surgery. And secondary outcomes included total inpatient opioid use up to the day of discharge or up until postoperative day number 7. Pain scores as assessed by a 10-centimeter visual analog scale, as well as the NIH PROMIS 3A pain questionnaire and the Hercules quality of life survey. In order to calculate the sample size, we hypothesized that liposomal bupivacaine would confer a 30% decrease in total morphine milligram equivalents in the first 72 hours when compared to placebo. And in order to accomplish this, 54 patients per arm were needed. Here you see the flow diagram. 174 patients were enrolled in the study, and after excluding 10 patients, the total sample size was 164 patients and allocated as indicated. 57 in the liposomal bupivacaine group, 55 in the simple bupivacaine group, and 52 in the placebo arm group. Here we see the patient demographics. The median age was 59 years old, the median BMI was 38.2, and the median hernia width was 15 centimeters. And we see no baseline differences between the study groups. Looking at the intraoperative details, all patients received a permanent synthetic mesh placed in the retromuscular position and fixated with absorbable transfascial suture circumferentially. Again, there is no differences between the groups when looking at the intraoperative details as well as the intraoperative complications. As far as the opioid requirements, all study arms received this similar intra-op opioids. And looking at the first 72 hours, the initial 72 hours of the surgery, there was no differences between the study groups when looking at the morphine equivalent milligram requirements. Again, we then broke it down into single postoperative day, and similarly, there were no differences between the study groups looking at the post-op day 0 to postoperative day number 7. Assessing the pain scores as reported by patients using a visual analog scale, all study arms had similar baseline pain scores, and again, there were no baseline differences when looking at the pain scores before the surgery and also postoperatively in the immediate post-op period up to 30-day postoperative day. Finally, looking at the PROMIS and Hercules scores, we assessed this in 2 time points at baseline at the 30 days. All study groups had similar baseline pain scores as assessed by the PROMIS 3A, and also they had pretty similar 30-day pain scores. Assessing the quality of life with the Hercules, both at baseline and 30 days. Again, this is trying to sound repetitive, but there were no differences between the study groups at these 2 time points. So in conclusion, this study compared the efficacy of liposomal bupivacaine, simple bupivacaine, and placebo in open abdominal reconstruction. And our study found that liposomal bupivacaine tab blocks had no clinical benefits as assessed by total opioid use, pain scores, and also patient-reported quality of life. I'll take any questions.
Aldo, I'll thank you for giving this talk. It's provocative. Why do you think the findings were that there were no differences?
Actually, the findings surprised us as well. I didn't go into much detail in this presentation just for the time's sake, but I was part of the group that assessed the pain scores. And we're actually quite shocked when we found the results. We were, of course, blinded to the treatment arm. And actually, one of the only statistically significant thing that was that the study showed was how wrong we were at guessing which treatment patients got. So I think the open abdominal reconstruction is it's a big surgery that Exparel might not overcome, especially in the first 72 hours post-op.
Well, maybe I'll add one thing to that. So thanks, Aldo. That was a great study to run, and thanks for the presentation. I think kind of what this shows, like every study, there's limitations, and at the end, and you don't find out what you thought you would, you kind of look back and think of what you would do differently. So I think what this study shows is that these were tap blocks performed by the surgeons at the time of a TAR, where we're looking right at the transverse abdominis muscle. And I personally believe that those injections were done accurately. But I think what this shows is a surgeon-directed tap block might not do anything. Whether or not an anesthesia or ultrasound-guided tap block might have a different outcome with or without Exparel, I think it's actually being studied right now by our anesthesia department. And I think the other thing that this begs the question of, which we should all just take a minute and think about, is that the tap block might not do anything. There's really never been a study that shows that a tap block versus a placebo does anything. All the studies are mostly off of Exparel versus, lidocaine or bupivacaine. There's never been versus a placebo. So, I think that this challenges some of the thoughts about it. And just to kind of conclude with this is our group, we have completely abandoned Exparel. Nobody in our group uses it anymore. It's with the volume that we do, it's probably $75,000 a year of savings for our group in doing that. So I can't tell you that we've, noticed a big difference, but it was a little bit shocking to us as well. That's not what we thought we'd find, but that's why we do the science.
And if you're someone who believes that perhaps surgeons do accurate tap blocks, I think the counter argument to that, the Pacira reps make a big deal about the fact that Exparel needs to be in the right plane because of the size of the molecule. It can't diffuse between layers in the abdominal wall. And so the counter to that would be, well, if that's the case, then the non-liposomal bupivacaine, regular bupivacaine, does have some ability to go through the layers of the abdominal wall and diffuse. And so if you are a little inaccurate, if you're one layer off, you should still have some effect. So if that was the case, and the regular bupivacaine had the best or had some difference on day one, that would be the argument that perhaps we're just not doing it accurately, but that didn't show it as well.
So I think Mike and Clayton, partly because of time, but I see a theme here where there are comments about the OnQ pain buster pump being used for no opioids. And I did some consulting for Heron Therapeutics, and they just got FDA approval for Zenrelef, which is a 3-day concoction of bupivacaine. I think there's a lot of things coming out on the market, and with the QC and our task force, we can even look at these things or at organizations and see which are going to make an impact, because this goal to no opioids is real, and there's a lot of things coming on the market that may or may not be helpful at all. So this is a great talk, and opens up more questions than answers.
Can I make one quick summary statement? Oh, sorry, go ahead, Rana.
No, go ahead, good.
I was going to make one summary statement about tonight, and I think everybody's talks, these were phenomenal talks, but most importantly, what I think all of these talks are about when we start to transition now from being a simple registry that collects data to a quality improvement / quality collaborative, where we actually take this data, which is our own data, and we start to figure out if we're willing to change our practice based on this data. I think everybody eloquently put that this is the challenge now, and for each surgeon to kind of individually look at this and ask yourself, really now, I'm putting the effort to put the data in. They're analyzing the data, they're feeding it back to me. what does it take for me to change? And I just, as my one kind of message to everybody, the beauty of the QC is we get folks to change, and then you can still measure if your change was a good or a bad idea. So we'll still follow these things, and sometimes we'll be wrong, and we'll be able to figure out, nope, that wasn't the right thing to change. So I just, for everybody and all the great speakers tonight, that's really what this is all about, is now the tough stuff of, put the data where, and putting it to use and being brave enough to change some things. So I think the opioid task force, to Courtney with all the work on abdominal core health and for the randomized trials that are being done, this is what this is all about. And this is kind of that next monumental step. We're about a decade into this now. We've all got to decide, what are we going to do with this information as we move forward?
Yeah, really great. Thank you. And just to emphasize that and what Ben said in the chat, this is what separates an effort like the QC from other organizations, because we base our discussions on high level data. So both of you, thank you so much for your leadership, and thanks everyone for joining us tonight. If you have any other questions for us or the presenters, please let us know. And sorry for running over time, but thank you for joining us. Take care, everyone. Have a good night.